Acute problems with GI function. So our unit objectives are to apply the core knowledge of normal anatomy and physiology to the management of patients with acute alterations in GI function. Discuss the medical and nursing management of patients with liver and pancreatic cancer. Discuss post-op care for liver transplants. Differentiate signs and symptoms in nursing management between acute and chronic pancreatitis. Differentiate screening protocols, risk factors, and treatment modalities for various types of colorectal cancers. So our topics are going to be liver cancer and transplants, pancreatic cancer, colorectal cancer, acute and chronic pancreatitis. So this is just my little cartoon. Hey Loon, what's with the pillow? Doctor's orders. He told me to use a stool softener. Little GI joke. Okay, hepatocellular carcinoma, liver cancer. The incidence, it is the 5th leading cause of cancer, increasing with in the United States, especially among African American men aged 45 to 55. Cirrhosis from chronic HBV and HCV, Hep B and Hep C infections. Cirrhosis from any cause increases your risk. The clinical presentation of liver cancer is abdominal discomfort, elevated alpha-fetoprotein, and alkaline phosphatase, so some of your liver enzymes. Our diagnostics are using ultrasound and contrast CT to detect metastases, CT or ultrasound-guided liver biopsy. Now, if your patient has a liver biopsy, your positioning is going to be kind of unique. Normally, when a patient has some kind of a procedure, we position them on the opposite side. With a liver biopsy, which will be on your right side of your body, because that's where your liver is, we're going to have them lay on their right side, because the liver, being a very vascular, bloody organ, very high risk for bleeding after a liver biopsy. If they're lying on their right side, that causes the liver to kind of press up against the inside of the peritoneal cavity and makes a little compress, so to speak, to reduce the risk of excessive bleeding. Our treatment for liver cancer is surgical resection if it's only confined to one lobe. Otherwise, it's very difficult if it's really all spread all over the body. So only about 25% are going to be surgically resectable. We can't use radiation because the liver can't tolerate that. We can use hepatic artery embolization or radiofrequency ablation, so basically blocking the circulation to the tumor or freezing and destroying the tumor. Chemo via implanted infusion pump or catheter, or they could have a liver transplant. Now, a liver transplant, here's a picture. All these little white areas are little areas of cancer. All this yellowish area is cancer. So for the liver transplant, that's most commonly for end-stage liver disease or acute liver failure, but can also be done in certain situations of primary liver neoplasms. Primary meaning the tumor originated in the liver and it has not metastasized to other parts of the body. So metastatic liver tumors from other parts of the body would not be an indication for a transplant. It's a very expensive and not a whole lot of livers out there available. So they are going to make that person who is the best candidate will get that liver. Other contraindications for liver transplants would be severe comorbidities like cardiovascular and respiratory conditions that would prevent that patient from surviving such an extensive surgery, active alcohol or substance abuse, or inability for self-care. Patients need to be able to identify and respond to any kind of reactions of non-function or rejection, and also continue to take consistently their anti-rejection medications for the rest of their life. So potential complications, we can have what's called primary graft non-function, which means that the transplanted liver doesn't work, and so the patient needs to have an immediate retransplantation, or they are going to die from liver failure. So that would be indicated by elevated liver enzymes, which should not be the case if that liver is functioning normally. Bleeding due to coagulopathies. Our clotting factors are produced by the liver. If it can't produce clotting factors, then patients can hemorrhage. Infections because of the immunosuppressant medications. They can have acute graft rejection where they will have very similar signs and symptoms from when they originally presented with acute or chronic liver failure, like tachycardia, right upper quadrant flank pain, jaundice, elevated enzymes, and gallbladder tests like bilirubin and that sort of thing. So our treatment for rejection will be to increase the immunosuppressant drugs, which will put them at a higher risk for more infections, and hopefully we can stop that rejection process. Pancreatic cancer. It is the fourth leading cause of cancer death. It is very difficult to diagnose in the early stages because of where the pancreas is located, surrounded by other organs, and also it has a very poor response to chemotherapy. So they have very vague, non-specific signs and symptoms in the early stages. It's difficult to diagnose it, and then it's difficult to treat because it doesn't respond to the typical GI chemotherapeutic agents that we use for other types of GI cancers. High risks are over the age of 65, history of smoking, 10% have a familial history, chronic pancreatitis, obesity, and patients will have jaundice, vague, non-specific abdominal or left upper quadrant pain, because that's where the pancreas is, clay-colored stools, because if the common bile duct has been blocked by the pancreatic cancer, bile is not getting into the stool, so it's causing clay-colored instead of the dark stool. Dark urine because of increased serum bilirubin, then that's what's going to be diuresed out by your kidneys. Dark urine, nausea, vomiting. Hyperglycemia if the cancer is impacting your beta cells that produce insulin. DVTs, weakness, and fatigue. So here is a whitish area. Here is that pancreatic tumor. We can do minimally invasive surgery via laparoscopy, or we can do something called the Whipple procedure for extensive, very extensive abdominal surgery where they're removing the head of the pancreas, the distal end of the stomach, maybe even a total gastrectomy, removal of the upper end of the colon. They take out the gallbladder just because they're in there. They might as well. So the post-op care is going to be focused towards what you would anticipate, as you learned in Nursing 110, for patients who have had major abdominal surgery. And then our non-surgical treatment for patients who are not appropriate for surgery for pancreatic cancer will be chemo, limited effectiveness, radiation, and high doses of opioids for pain control. So now let's talk about acute and chronic pancreatitis. So first of all, acute pancreatitis, knowing what the exocrine functions of the pancreas are. The exocrine functions are the enzymes that it secretes that aid in digestion. And they are secreted by the pancreas in an inactive form as they go from the pancreas through the pancreatic duct into the common bile duct into the small intestine. And then once they're released into the intestine, they activate and they start digesting the food that has moved from your stomach down into your small intestine. What happens with pancreatitis is that the enzymes are activated early, so instead of breaking down food, they're actually breaking down your pancreas and your pancreatic duct. or the pancreatic duct is blocked, so now those enzymes are backing up into the pancreas and then eating away and inflaming the pancreas. So it's early activation or blockage that can cause acute pancreatitis. We really don't know in many times what the causes are of why someone gets an acute episode of pancreatitis, but excessive alcohol ingestion, biliary tract disease, so gallbladder issues, traumas, certain diagnostic procedures can cause an acute inflammation or blockage of those enzymes or early activation. So our history is recent abdominal surgeries or procedures, infections, medications, alcoholism, history of chronic pancreatitis, and they will have a sudden, sharp onset of pain in the epigastric or left upper quadrant areas with radiation to the back, the left flank, or the left shoulder. Now, what you see here in this picture is something called Cullen's sign, which is an ecchymotic area around the umbilicus. There is also Turner's sign, which is that ecchymotic changes on the flank area of the patient. They will have tenderness, rigidity, signs and symptoms of peritonitis, weight loss, nausea, vomiting, absent or decreased bowel sounds, so hypoactive bowel sounds, or even paralytic ileus, ascites, as you can see in this picture, hypotension. Our diagnostic lab tests, specifically, we're going to be looking at our amylase, and if that's elevated, we know we've got problems with our pancreas. Lipase is another one that we would see elevated. We will see elevated bili or other gallbladder and liver diagnostics, elevated white blood cells because of the inflammation and infection, and elevated glucose because it could impact your islet cells, your beta cells that produce insulin. Respiratory status is a priority. We are at risk for sepsis, and which can bring us to that SIRS response, which can cause ARDS. Plus, they have very poor respiratory effort due to that high left upper quadrant pain that they're experiencing. We need to deal with that acute pain, and we need to do that by interventions that reduce GI tract activity. So the patient is going to be NPO, because anytime you eat or drink something, it stimulates enzymes to be secreted and into the excreted and into into the digestive tract. So we need to decrease GI tract activity. So they're going to be NPO. They may have an NG tube. They need a lot of pain medication because this is extremely painful. They tend to lie in the fetal position or kind of sitting upright, leaning forward over their bedside table. That helps to reduce some of their pain. And then surgically, we may have to go in. We can do a laparoscopic cholecystectomy, remove their gallbladder. If they have abscesses or cysts, we may be able to go in and drain those cysts to reduce the pain and inflammation. And here's a whole boatload of potential complications that can happen with acute pancreatitis. With chronic pancreatitis, it can happen because we've had a previous acute episode that has caused damage, and now it's a very progressive, destructive disease causing inflammation and fibrosis, and patients will have remissions and exacerbations with chronic pancreatitis. And the major pathophysiology is they have had a previous acute episode of pancreatitis, they have alcohol-induced pancreatitis, or chronic obstructive, or an unknown cause. And so with chronic pancreatitis, we have dull, nagging left upper quadrant pain. So with acute, it's a sharp pain in the left upper quadrant. With chronic, it's a dull, nagging left upper quadrant pain. Vomiting, weight loss, steatorrhea, Steatorrhea, which is frothy, fatty stool, clay-colored stools, jaundice, elevated glucose because of possible damage to your islet cells, your beta cells. Diagnostically, we are going to do an ERCP, MRI, a CAT scan, analyze their stool. And patients with chronic pancreatitis, we need to support them with IV fluids. Oftentimes they're on TPN because of their nutritional deficits. PPIs or histamine antagonists to prevent GERD and damage to their stomach. They can have certain drainage procedures if that is appropriate. They can have a pancreaticojejunostomy. You may have heard it called a Roux-en-Y, which joins the pancreatic duct to the jejunum. They can have that Whipple procedure where we remove the head of the pancreas, the duodenum, a portion of the jejunum, partial or total gastrectomy, or a cholecystectomy. They could actually have a transplant, a pancreatic transplant. So chronic pancreatitis, there really is no cure unless they get a transplant. Diet therapy. So we need to reduce pancreatic secretions. So NPO, fluids, electrolytes, possibly TPN, tube feedings into the jejunum because they won't stimulate pancreatic enzymes. And then progress from clear liquids to regular. They need to avoid alcohol. They may need to take pancreatic enzymes to help with digestion. They need to have small, frequent meals to reduce the stimulation of the pancreas at each meal. Now, I had a student tell me a story once about a patient that had pancreatitis and was in their hospital room. They had their TPN going. They had their NG tube to low wall suction. They were NPO. And they could not control the pain for this patient. Turned out, while he was laying there in the hospital bed, he was watching the Food Channel on TV. And every time they talked about food, or every time a commercial came on for food, it stimulated his pancreas to produce his enzymes, and it's caused increased pain. So the poor guy, they had to turn off the TV and keep him away from any kind of smell or sight of food that could stimulate his pancreas and cause increased pain. That's kind of an extreme example. Colorectal cancers. The incidence is decreasing probably because of improved screening and improved treatment. The mortality and the incidence has declined. Those of you older students probably remember Katie Couric, who used to be one of the hosts for the Today Show on NBC many years ago. And her husband, they were in their 30s, I believe, or early 40s. Her husband was diagnosed with colon cancer and died from it. So she decided, as a public service approach, she basically televised her colonoscopy live on the Today Show. And telephones were blowing up at GI doctors' offices and cancer screening centers from people who are wanting to make appointments for their colonoscopies. It was such a taboo subject prior to this. Nobody ever wanted to talk about colorectal cancers and colonoscopies until Katie Couric televised her colonoscopy on TV, and the response was phenomenal. And because of that, so many colorectal cancers are being detected much earlier. Used to be that they wanted you to start having your colonoscopies at age 50. They've kind of bumped that down to age 45. There is a high familial link and even some genetic mutations that can cause colorectal cancer. So these are in the notes in your PowerPoints that are kind of interesting to look at. The polypectomy is the best preventive treatment, so that's what can happen when you have your colonoscopy and they find polyps, they can remove them. Dietary, there are some links to that, so I call it the McDonald's diet. High fat, fried meats, high refined carbs. There are some conflicting studies, but by and large, most of your GI docs are going to say that type of diet is a risk factor. If you have a history of inflammatory bowel disease, especially ulcerative colitis, about 10 years after your diagnosis, you start becoming a much higher risk. There are various preventive measures, NSAIDs, the COX-2 inhibitors like Celebrex can help to reduce the number of polyps. The signs and symptoms are, again, very vague and non-specific, kind of dull abdominal pain, maybe a little blood in the stool, and the person's asking themselves, oh, is that from my hemorrhoids? And they say, yeah, it's from my hemorrhoids, and they kind of ignore it. Changes in their bowel habits. Usually what gets people to the hospital is, extreme anorexia, weight loss, anemia, fatigue, that sort of thing. The screening, if you are an average risk, used to be age 50, now they're saying age 45, have your colonoscopy, and then every 10 years after that. If you have a family history, then you should start your colonoscopies at age 40 or 10 years before the youngest person in your family came down with colon cancer. If you have the familial polyposis, they start with colonoscopies at age 12, and oftentimes by age 25 they will have a prophylactic colectomy and permanent colostomy, because 80% of patients with familial polyposis will develop colon cancer. So they do that as a preventive measure by the age of 25. The other HNPCC, the other familial type, they will start their colonoscopies around age 20, 21. If you have IBD, they will start you yearly colonoscopies about 8 years after the diagnosis, because it's around year 10 and later that you become at risk. Staging of cancers, colon cancer. So they use the TNM staging categories that you learned about in Nursing 200. So stage 1, which is a T1 or 2, 1 or 2 tumors, no node activity, they will do surgery. Stage 2, where you have 3 to 4 tumors, no activity, no metastases to the nodes, surgery with or without chemo, and that's totally up to the physician, because there's no significant difference in prognosis and outcomes whether they have chemo or not with stage 2. With stage 3, where you have up to 4 tumors and there is the involvement of 1 to 2 nodes, surgery with chemo. And stage 4 will be your metastatic. They will do chemo, and they may or may not do surgery. Usually about only 10% will do surgery for stage 4. There are various combination drugs. 5-FU in combo with some other agents is a very common one that is used to treat colorectal cancers. Interferon biologics can be given as well. And some of the side effects are something called hand and foot syndrome, not to be confused with the hand and mouth thing that kids get, where patients will have a severe redness and inflammation on the palms of their hands and the soles of their feet, which, as you can see on this foot one, the skin can crack and it can become infected. And these are kind of mild pictures. There's some pretty gruesome ones on Google Images that I elected not to include on this, but those can be a side effect that will resolve once the patient is no longer having chemo. Surgically, we can do a colon resection with anastomosis, which means that we cut out the section of colon that has the tumors and we reconnect the other ends. We can also, they may remove some of the nodes, regional nodes. We can have a colectomy and a colostomy, where they remove a significant section of the colon and do either a temporary or permanent colostomy. An abdominoperineal resection, or A&P resection, where they remove, this is for lower end of the GI tract, they remove the sigmoid, the rectum, and the anus through a combination of abdominal and perineal incisions, so that there will be an abdominal dressing, there will be perineal incisions, probably drains, and so forth. Post-operatively, you need to be looking at your stoma for appropriate color. Should be beefy red, it should, or at least a dark pink. It should not be pale pink or pale or purplish or black. Usually the first stool that you get through your colostomy is going to be a little maybe brownish water, because they've usually been NPO and pretty well cleaned out prior to surgery. But then depending on how high in the colon the colostomy is, it will either be watery and runny, or it will be more solid and formed. So here's a picture of a resected section of colon, and that whitish area in the middle is that cancerous tumor. And this is where you're kind of looking down into the colon, and all this whitish cauliflower looking area here is tumor that has to be removed. Now, there is a case study on pancreatitis that is posted on Canvas that I highly recommend that you use to prepare this. Pancreatitis is a topic that likes to come up on NCLEX and ATI and those sorts of questions. It's a very popular concept. So doing that case study would be very helpful as you are preparing for the NCLEX and the predictor.